developed fever, which was undocumented, mild, relieved by medications, and the child was active in interfebrile period. For this, she went to a local doctor and received symptomatic treatment, and the fever resolved within 2 days. 2 days later, she woke up at night to use the washroom, but she was unable to lift her legs and walk to the washroom. She was also not able to sit, stand, and walk independently. Although there was no upper limb weakness that was noticed. Next day morning, mother noticed that the child was initially irritable and was not interacting with them. This was followed by lethargy, and later she was also not responding to any of their commands. Also, the mother said that she had also passed urine spontaneously the next morning. For these complaints, she was taken to a local hospital and was referred here for further management. A history of decreased oral intake was also present. There was no history suggestive of any upper limb, trunk, or neck muscle weakness, no history of drooling of saliva, no history of any tingling, numbness, or any abnormal sensations. There was no history suggestive of any cranial nerve involvement, no history of photophobia or headache. There was no history of cough, cold, ear discharge, no history of any cox or cox contact, no history of loose stools, vomiting, receiving any vaccines recently, no history of any drug or toxin exposure, no history of trauma or fall or any similar complaints in the family, no history of difficulty in breathing, choking, or any history suggestive of aspiration. Patient presented with above complaints and was immediately put on mechanical ventilation in view of poor sensory and was started on IV medications. Currently, she is on room air, sensorium has improved, and also she follows commands and is able to move her lower limbs as well. Past history, no history of similar complaints in the past. No history of any previous admissions. Antenatal history was uneventful. Birth history was uneventful with full-term normal vaginal delivery, birth weight of 3.5 kgs, cried immediately after birth. No history or no history of any neonatal complications. The child was immunized till date according to the national immunization schedule. Developmental history, all the milestones were achieved, age appropriate milestones were achieved. The child was developmentally appropriate for age. Dietary history, there was no protein or calorie deficit, and the child comes from the family pot and consumes all the food groups. Socioeconomic history, she belongs to lower socioeconomic class. She has two siblings and no history of similar complaints in the two siblings is present.
Rajesh, the slides are not moving ahead.
Five, 6-year-old girl, right? 5-year-old girl. So 5-year-old girl, fever for 6 days. How long did the fever last?
Lasted for 2 days.
2 days. And then after a gap, this happened. So 2 days fever, 2 days nothing, and then this happened.
Then 6 days prior to admission, then 2 days fever had resolved. Yeah. Now weakness and altered sensorium.
No. 6 days prior, fever for 2 days. Then fever resolved within 2 days. So there was a gap for 2 days when there was nothing. And then after 2 days, the weakness. Okay. So she got up and was not able to go to the washroom. So now, what do you think? Where is the anatomy of the problem?
Not able to lift her lower limb. So majorly it was in the bilateral lower limb. So could be starting of an acute flaccid paralysis or ascending paralysis.
Yeah, that it could be, but we'll go systematically. So first we'll decide that if there is weakness, first of all, that there is weakness. So that you said she's not able to lift the lower limbs. There was weakness. Painful or painless?
Painless.
Painless. There is a difference between painful and painless weakness of lower limbs. Difference in your interpretation. Take the mic.
Painful could be vascular cause, acute onset, painful.
Okay. So painful could be vascular or
Unilateral would be more than trauma. Can think of that, and this is three. If painless, will think of one could be muscular cause. Viral myositis could be one of the DD.
so first we are talking of broadly. So when we say broadly, what we mean is that painless is almost always neurological. Painful may be neurological, may not be neurological, right? Okay. Now, if this is neurological, then where is the problem? So start from central nervous system, then come to peripheral nervous system, upper motor neuron, lower motor neuron. So go that way and try to answer where is the problem.
Sir, we cannot hear you. Rajesh sir, we cannot hear you. Rajesh sir, we cannot hear you. You are not audible, sir. Rajesh sir, can you hear us? You are not audible.
I'll call him.
Yeah, ma'am, please.
I can't hear you.
Rajesh sir, we cannot hear you. You are not audible. Sir, no sound at all. Rajesh sir, no sound at all.
Related to that. And what is the relation?
Yes,
Immunization.
sir. Yes, sir. Audio is there now.
Infection induced immunological
Yes,
disorder.
we can hear you.
We call it encephalopathy. Vaguely, we have no clear idea what else are involved. But there is often a discrepancy between what MRI shows and what a clinician shows. MRI shows structural changes. Clinician looks at functional change. To that extent, it is not rare to find MRI showing something much more than what we can visualize, or even sometimes vice versa. What we can see are not structurally seen in an MRI. So the discrepancy is not unusual. And therefore we would say this child has got an infection triggered immunological encephalopathy. Okay, this acute is disseminated likely. Okay, this encephalopathy is maybe along with that myelopathy. Polyclonal, that's what we would start thinking of. Could it be infection there? No. It has to be inflammation. Why inflammation? It's an acute onset, but not ultra acute to consider vascular. Vascular lesion would have been within a short time. This is taken a day or two to come up after a gap of 2 days, after that 2 days of it. So this is typically an autoimmune encephalopathy. What is the syndrome? We only know maybe after investigation. So your diagnosis should have been based like this. The weakness certain, one or lower, most likely. We need to wait for progress. If progress looks up, so you call it encephalopathy. The wait one. What kind? Infection induced immune, call it an ADM. With or without myelopathy. It could be myelopathy as well. Plus encephalopathy. Or it could be to begin with encephalopathy. Bilateral frontal lesion to disseminate. Therefore, I use the word acute disseminated encephalopathy. These are made of myelopathy. And alien could be only myelopathy. Alien could be only encephalopathy. Or offered together, and that's why we call it both encephalopathy. You know that the child has low motor start, and then the encephalopathy manifestations came in. It started with lower motor neuron. The encephalopathy manifestation could be as a result of the progressive paralysis involving the intercostal muscle, the respiratory muscle, and the encephalopathy can be hypoxic or because of metabolic. But the sequence has to be started with lower limb. Then came the difficulty in breathing, hypoxia, and then came the here if the both the things have come up more or less simultaneous. There has not been much gap of more than a day or and then the institution of पहले lower limbs नहीं, फिर upper limbs नहीं, then there was difficulty in breathing and then so though in some cases of like yes, the epileptic manifestation and the occurrence is different. The chronology is different. Here the things are happened more or less simultaneously. There has not been a phase where there was a attack. And then lowly weakness, we as usual go muscle and go muscle or here there is some problem with retention of. So when we think of retention of sphincter disturbances, we also think of a cord. But this particular child would have had retention even in any past. We're not very sure whether there was really any involvement of that or otherwise we have to think of involvement of God as well. We have to think of an involvement of the God. Then again we have to think of alien because it will be higher gas or
Any of you are technically good? Come here.
because it is a core region. It needs to be both sensory
Join
and motor.
audio तो नहीं हो
Where
रहा
there is
meeting
only
में.
motor involved. But probably primary coordination like transverse everything, the chronology appears to be rather important and hypoxia giving us from this like. Most of the neuromotor neuroinflammation is so extremely muscular and cause a respiratory pain is to begin with ventilatory. So it is hypoxia will come much later because to begin with ventilatory respiratory is hyperthermia. And of course thereafter pain will also. So if you look at SLA for example, okay, only SLA 1 which progresses at the time child is 9 months, 10 months, is going to be almost proceeding to respiratory failure. But to begin with ventilatory will have due to waking up. And thereafter at the end, oxygen. And then oxygenation alone will not help. So it has to be respiratory. So that's why that is a rare event. And that is an event that also
वो जाने दे.
that's why probably it's a myelopathy and encephalopathy. In different reasons, again encephalopathy both. Okay. And therefore we call it a dyspnea.
You can take it further. I'm just.
I think that's what it is. See, one idea of this discussion is to make you a thinking process in a sequential. Anything will be wrong because examination might show you
602 938
So the whole examination license
777.
it is both myelopathy plus encephalopathy or it is only
Sleep.
and the examination can easily spell out. That's the way. As a result of respiratory muscle on the central suggestion of the respiratory muscle mass, like distress and going on worsening, has happened relatively suddenly. Is the central respiratory problem
rather than the respiratory muscle giving rise to symptoms.
Examination.
And I think that is there. There is a respiratory failure coming up. Not neurological or respiratory. If it's an acute disease, then you don't get unable to show neurological manifestation. You die much earlier than you started with concoction much before the seizure or anything comes in. So that is how possibly an acute disease, like an acute liver cell failure dies without jaundice. Because it's metabolic. There's no time for developing jaundice. So I think but we need to kind of keep all these things in mind. Let's see what we will physical examinations.
And often when we want to entertain central nervous problem, we often tend to think that it has to be unilateral, bilateral involvement, both arteries involved, less likely. In central problem, you should have cortical involvement, so seizures, etc. But not necessarily when the problem is occurred acutely. And it has involved the respiratory centers much earlier than the cortical involvement, so the seizures have not yet come.
Yes, PPT is visible, sir, now. PPT is visible.
Can you hear?
Yes.
Yes, we can hear.
Yes, we can hear.
Summary: 5-year-old female child presenting with acute onset lower limb paralysis with altered sensorium without bulbar and truncal involvement with history of bladder involvement at onset, preceded by acute febrile illness, now showing improvement in a completely immunized and developmentally normal child, is a case of periparesis with encephalopathy secondary to acute disseminated encephalomyelitis to rule out meningoencephalitis, CNS vasculitis secondary to CNS tuberculosis.
Can we debate all that? Pick one of them and start saying whether you agree or not.
Encephalitis component is there. Meningeal component on examination if we can find.
Anyone else?
Meningoencephalitis, as she shared, we can examine and then see if signs of meningitis are there. We can keep the differential, but child will be more irritable and then have photophobia, all those in complaints, headache, vomiting, which are not there. And in CNS tuberculosis, um, do not usually present with weakness.
Actually, meningoencephalitis means meningitis plus encephalitis. Okay, which itself combination is not common. So we often talk meningoencephalitis. Meningitis per se is headache, vomiting, okay, irritability. That's meningitis. That's typically acute bacterial. Then encephalitis without meningitis is typically acute viral. When we are talking about infection. And meningoencephalitis is classically a tuberculous disease where you have both meningitis as well as encephalitis. Okay, so let's make that clear. It could be viral meningitis, okay, which is not.
Rajesh sir, you are on mute again. You are on mute, sir. Kindly unmute. No, sir. We cannot hear you. Sir, kindly unmute. Kindly unmute.
Except moya, which can cause the. But the highlight is the sudden onset of a vascular event. This was not sudden. This took some hours. And therefore, this is unlikely a vasculitis per se, like a moya. It is to be multiple vessels in. Therefore, vasculitis is unusual. Meningoencephalitis, if you are looking at infective, less likely. And then you have a serious tuberculosis, which is meningoencephalitis. So now debate whether it could be tuberculosis, meningoencephalitis, and vasculitis. So we will combine all first three into one statement, that is TB. We will give a thought whether it could still be a tuberculosis meningoencephalitis and vasculitis. Vasculitis and meningoencephalopathy is a pathology of tuberculosis. Therefore, we are using those. So you can have, for example, a basal ganglia lesion, heavy vellocis, all that is a vascular. Hemiplegia, typically in epithelium, is a vascular lesion. Plus there is a meningitis, plus there is a seizure, encephalitis. So who will argue for or against tuberculosis meningitis or combining all three? You get the point? Don't talk it. Doesn't matter. When we talk, we are not necessarily correct. But what do you? So, how did this whole illness start? Correct. But typically, most of your TB, CNS infections, how do this? Is it a slow, gradual onset, or is it like one minute the child is walking and the next minute the child is? So, sir is asking from that point of view in this story, do you think TB meningitis?
Kind of makes tuberculosis unlikely. But it has an acute onset. Tuberculosis could have a gradual.
The younger the child, the manifestations are. If you see a 6-month or a 10-month-old initially, he would come with a history of cold fever, and then suddenly it ends with encephalitis, which means seizures and now, when prior to that, he's not doing good. So it is not an acute manifestation of tuberculosis, but it's an acute manifestation of a silent tuberculosis disease with acute manifestation neurology. So that small infant for a young toddler is not doing too well for last few weeks, but he's going on. And suddenly develop within 2-3 days, irritability, fever, unconsciousness, seizure, and comes to as a TB meningoencephalopathy. What do we mean by that? Manifestations are neurologically acute encephalopathy. Okay. Not much meningitis. There is no irritability, vomiting, much less. Take encephalopathy. As the age advances, then the manifestation of neurological TBM is more of meningitis, less of encephalopathy. But failure is sitting exactly in the middle. He could have both. But he must have both. Here there was no story of a meningitis, which is headache, vomiting, irritation. There was no. There was no symptom of acute encephalopathy like seizure or unconscious. To that extent, this is unlikely a TB meningitis. If you see an adult or a 12, 14-year-old child with TBM, it comes exactly like a bacterial meningitis. But the story is a little spread out over few days or weeks. It's not high fever, but it looks like a bacterial meningitis. It's low-grade bacterial meningitis. And tuberculosis is a bacterial meningitis, but low grade. So we call it not usually, but tuberculosis. This is unlikely to be tuberculosis. Now, we are often fooled by tuberculosis. So we should keep that in mind in our epidemiology. But this is not a story of tuberculosis meningitis.
For example, tuberculosis can cause also myelitis and only low motor neuron, nothing up there. But those are rare. It's called spinal arachnoiditis. Okay. But so therefore, possibly to my mind, the last one on the list is more likely than the first three. But my point of explanation was first three are together in tuberculosis etiology, though this doesn't fit in that, right?
Let's imagine for a moment that there was no lower limb weakness, okay, for 2 days. Then it is a typical story of encephalopathy or encephalitis. Suddenly, the child is coming with altered sensorium and going down, and also involvement of a central respiratory paralysis. And all. Here, the lower limb paralysis is giving us some guidance, but not necessarily the. In the absence of the lower limb weakness, also the diagnosis would have been encephalitis. Because there is low limb weakness, we are calling it more of a disseminated.
Share this again, Amdekar.
So, when the child had presented to us, the child was lethargic, and also currently the child is recovered, so there were no positive CNS signs. On examination, the child was afebrile with heart rate of 100 per minute. The pulses were felt at all peripheral sites, regular good volume. Heart rate was 20 with no signs of respiratory distress. BP was at the 50th centile. Saturation was maintained. Extremities were warm. Perfusion was good. Uh, Head, hair, eyes, entire head to toe examination was normal. No neurocutaneous markers were present. Anthropometrically, the child was normal. CNS examination wise, the child was conscious but irritable. Vision was normal. Pupils were bilateral, equal, reacting to light. The direct and indirect reflexes were present. The apparent squint was present. The child was able to move his eyes in all the directions. No deviation of angle of mouth or drooling of saliva was noted. Nasolabial folds were preserved. The child was responding on calling and was also interacting now. Gag reflex was present. No apparent shoulder drooping was present. The child was moving on the bed from side to side, was able to move all his forelimbs. No apparent wasting was noted. Tone of muscles of all the forelimbs was normal. Power upper limb was more than 3 by 5 in all the muscle groups across all the joints and as well as in the lower limbs. Reflexes, superficial reflexes were intact. Plantars were flexor. Deep reflexes, all the reflexes were intact. No meningeal sites were there. No sweating or any tachycardia was noted. CVS, RS, and abdominal system examination was within normal limit. When the child had presented, the child was lethargic. Also, the lower limb reflexes were absent and extensors were plantars were extensors. So the child was immediately intubated in view of poor sensorium. Uh, he received IV medication, antibiotics. He has also received steroids, and after which now the child is extubated and currently on rumor. He got extubated yesterday only, and now the power of muscles is more than 3 by 5. Investigation wise, CBC was within normal limit except when TLC was 18,000 initially. Electrolytes were normal. RFT, LFT was normal. CSF analysis was done. So TLC 12 cells with 10 lymphocytes and 2 polymorphs. Proteins was 11 mg per deciliter. Sugars were 147 with a corresponding HGT of 101. A CT scan was done, which was suggestive of meningoencephalitis and EDEM to be ruled out. MRI was done. The provisional report is suggestive of EDEM.
How do you explain your examination is normal? Okay. Examination is normal, right? Nothing abnormal. Then what's your diagnosis? Forget the reports. Your edema is normal on examination. So who will counteract my statement? You get the point? History suggested ADEM examination was totally normal. How can ADEM have a normal examination? So either history is wrong or examination is wrong. Will you agree? But no, she has done correctly everything. So now who will still argue that history was suggestive of ADEM and examination was normal? Both statements are right. How can you convince me they are right? Come on, give a thought. Not difficult. You don't need to read Nelson for this. You have just to think without Nelson.
UMN lesion in the initial stage with the neuronal shock. The the explanation, sir.
So what you are saying is, when history suggested ALM and examination is normal, you would have said this child has already improved or cured. Okay. Now tell me why cured. She said it could be shock that we talked about ALM. Okay. But we did not talk about neurogenic shock. Okay. So it was an ALM. So can there be any other reason that the child gets better by, for example, a child comes with viral respiratory infection on history, or you have a viral URI, but on examination normal. So what does it mean? Self-limiting disease. So do you think this is self-limiting disease? Then why they got well? So if it's not self-limiting, then doctor cured this child. What did she do? You put on a ventilation, give oxygen.
Child has received steroids.
Therefore, it's a steroid that has done a magic. Okay. My next question is, before you started steroids, would you have told the parent, don't worry, अभी एक दो दिन में ठीक हो जाएगा? Then why do you give credit to that steroid? I'm sure you would not have said that, no? दवा चालू करता है, अभी देख लेंगे क्या होता है, उम्मीद है ठीक हो जाएगा. Okay. And the parents would have said, wonderful, what a good doctor. 2 दिन में ही ठीक हो गया. So you got something unexpected. Whenever you get something unexpected, you have to beware. I did badly in the exam, but I got a gold medal. No, either that gold medal is not gold enough or you have not done badly, correct? But sometimes you might have felt you have done well, but you have not passed. So how do you debate that? You're right. It was steroid doing a magic. But would you have anticipated? And in medicine, when you get something unanticipated, that may not be a good thing to happen. So give a thought.
So if it was inflammatory, then body mm, would have got um, controlled that inflammation.
So your statement would have been that all immunological manifestations are difficult to decide what the progress could be. That's your first statement. You are lucky to get well suddenly, whereas you may be unlucky never to completely recover. Okay. And therefore, you say that it's certainly a bit surprising that she has done so well, but it doesn't mean that it never occurs. But you, therefore, what you would have told the parents, we hope this will work, but we have to wait and see how the patient responds. Now, I'll give you a typical ascending polyneuropathy. Okay. Now, when you start steroids, you're not sure how long it will take because immune system, how badly is reacting, we don't know. And therefore, if it was urticaria, by the time the patient comes to you, the lesions have disappeared by themselves. So extreme self-limiting immunological disorder. On the other hand, steroids quickly working. Okay. On the other hand, steroids may work but not completely. And therefore, this is a luck more than expectation.
Sir, there were some issues technically. So the online people have lost a lot of discussion. So they are requesting if you can summarize from the beginning in short what was the history, what two, three differentials we thought and ruled out which one, why. If you can
So
summarize.
this was a 5-year-old girl who came with a history that 6 days ago there was a fever for 2 days, which was self-limiting. In between 2 days, the child was normal, and thereafter, on suddenly the mother noticed that she could not walk in the middle of the night when she wanted to visit the washroom, and thereafter she thought that she could not even easily stand walk without support. So both the lower limbs were involved. Within a short time thereafter, she was drowsy. And this was the story with which this child came. Now, analyzing this story, it is very clear that after 2 days of fevers, which was self-limiting, there was a clear 2 days normal period, and thereafter the neurological issue came in. Obviously, this was not an infective disease, but it was infection-induced immunological disease. Could it be a tuberculous disease? Because TB could have a fever off and on, and we saw on first 2 days, then we saw off 2 days. So one could think whether this could be tuberculous neurological manifestation or it could be an infection-induced immunological. Then the question was, where is the anatomy? If this was the lower limb involvement, could it have been a lower motor neuron lesion or an upper but spinal lesion like a myelopathy or maybe the nerve root lesion? There was no apparent pain and there was no tingling numbness, so it is not bilateral peripheral neuropathy. It's not a muscle. It's not an anterior ulcer. And therefore, we said that it could be myelopathy, but progression will tell us where we stand. If it was a kind of a root lesion, it would go on increasing, go upwards, and develop chest muscle involvement, upper limb involvement, and therefore we had to wait at that stage to see what's the progress of the disease is. Thereafter, in 12, 14 hours, the child started getting drowsy, which meant that this was certainly encephalopathy. Then the question that we discussed was, could encephalopathy also come with a lower limb weakness? And the answer to that would be a bilateral frontal lobe lesion. Now, bilateral frontal lobe lesion of an immunological disorder with or without myelopathy, it was acute, it was disseminated, even it was only encephalopathy, it was both frontal lobes. So disseminated, plus minus myelopathy, so we called it by history white an ADEM. We discussed why it cannot be tuberculosis because a TBM is a meningoencephalitis, but at 5 years of age, there is usually an element of meningitis and also element of encephalopathy. What is the element of meningitis? Some irritability, but often at this point, some ill health prior to the onset of this disease. If this child was healthy otherwise, then that tuberculous disease was less likely, and therefore we said it is not likely to be TB meningoencephalitis, and therefore we called it an ADEM. Now, the further investigation on a physical examination, there was nothing abnormal at all. So we said that this means it was a self-limiting disorder or it was a steroid responsive immunological disorder. Now, steroid responsive has come up very early in the course of treatment, but still it can be possible. But we would not have anticipated that in the next 2 days the child would be absolutely all right. but that can still happen luckily. And we also discussed, therefore, that immune complications are difficult to judge in terms of progress or in terms of a final outcome. And therefore, outcome could take a long time to recover completely. Sometimes it not only takes a long time to recover, but does not recover completely and leaves behind some residue. On the other hand, it could be, as happened in this child, a quick recovery, almost back to normal, and that's why the physical examination was normal. I think that was the summary of this child.
Apparently, though it looked like, and Dr. Rajesh pointed out, that apparently it looks paraplegia and then becoming hypoxic, but the whole progress has not. If he was like that, then he became breathless, then his upper limbs were involved, then he became drowsy, then because that is more common event to occur in a paraplegic due to GBS. Here, in no time, his higher centers are. By evening, by morning, he was unable to. But within few hours, he became encephalopathic, altered, requiring even intubation. There is no involvement of respiratory muscle to explain hypoxia. In fact, it was primary something like an encephalopathy. The paraparesis just occurred in the beginning. And also in the examination, you find that there was power grade 3, grade 4, but the plantas were extensors. So it was not primarily a lower motor neuron problem. It was an upper motor neuron.
That's all, no? Child is doing well now. Okay, fine. Good. So I think we'll move on to the next case for today.
Good evening, everyone. I'll be presenting the short case for today. 2.5 years old male, third by birth order, born of non-consanguineous marriage, Buddhist by religion, Hindu Mar by community, resident of Ghatkopar, hailing from Maharashtra, and informant being mother, came with chief complaints of abdominal pain since 2 weeks on and off, vomiting since 2 weeks on and off, loose stool since 1 week. Child was apparently alright 2 weeks back, then he started developing abdominal pain, which was paraumbilical, not associated with intake of food, associated with defecation. There was no radiation of the pain. Vomiting since 2 weeks on and off, food associated with food intake, non-projectile, non-bilious, containing food particles. Loose stool since 1 week, it was watery, intermittent, small volume, not associated with blood or worms since vomitus. There was no history of fever, no history of Cox contact, no history of pica, no history of decreased oral intake, no history of similar illness in the past. There is no history of melena or hematomesis, no history of previous bleeding manifestations. Past history, there is past history of 2 previous admissions at the 1 year of age for bronchopneumonia with SAM with anemia requiring O2 support. There was a patch in the right lung of the child. At this time, child was requiring O2 support, received antibiotics, discharge on day 5. At 2 years of age for febrile convulsion with dengue NS1 positive. At this admission, there were 2 CBCs of the child were recorded, which showed normal platelet counts, 213 and 219 respectively. ANC for the child was normal. Birth full-term LSCS in view of previous LSCS. Birth weight was 2.8 kg. Baby cried immediately after birth. History of neonatal jaundice. Received phototherapy. Child is immunized till date. Developmentally age appropriate. Diet. Child is still on breastfeeds. There is poor weaning, poor dietary habits present. Diet of the child is predominantly milk based. On a Where's Google?
So actually 2, 3 other things. 2.5-year-old, and they talk about abdominal pain. Can a 2.5-year-old tell you that he or she has got abdominal pain?
2.5-year-old has abdomen, no? And that can cause pain also. So why is he asking like that? It's funny question, no?
When can a child localize pain?
That's the question.
No, hearing is different from localization of hearing. Right? So similarly, when can a child localize pain? 5 years. So then why 2.5?
But
He
they
can,
point,
Rajesh, he can half localize. He's
point to
2.5.
umbilicus.
So two things. Means I am asking because here there was nothing much in the history otherwise to make out. So two things. One is that uh, parents will indirectly kind of interpret or half guess that the child's abdomen is paining because there are related complaints to the abdomen. And if the child is irritable and crying, they will just put two and two together and tell you that iska pet dukhta hai. So I don't think a child will be able to communicate really that this. And about pointing to the umbilicus, that is the only landmark on the abdomen to point to. That is why they point to the umbilicus. So that doesn't have a great significance. In fact, that which pain is more significant, periumbilical or away from umbilicus. So therefore, pointing to umbilicus doesn't strengthen it as abdominal pain. So while taking history, keep these things in your mind. Your antenna should go up. If the mother says abdominal pain for a 2-year-old child, your first question be, how do you know that it is abdominal pain? Right? Because when a child 2-year-old comes to you for excessive crying, what all can it be? Which other pains can it be? Ear pain,
Abdominal pain, sleep weeks,
any obstructed hernia, headache. It could be a limb pain. It could be anywhere. So pain is not localizable at 2.5 years. So this child will come as excessive crying or irritability, right?
And I think therefore abdominal pain is only a child is uncomfortable. That's all. We don't know why. But vomiting is genuine. So what do you make out of this vomiting? Forget some discomfort must be there, but not a pain to discuss. Okay, maybe mild pain, what mother thought. So let's call it an abdominal discomfort. What does it mean? Some gaseous distension off and on. So gases pass, there's comfort. Again, gases accumulate, there is again discomfort. So looks like a gaseous distension to me or a gaseous problem to me. That is all. What does vomiting suggest to you? Vomiting is difficult to say. Liver disease can cause the vomiting, yes. Kidney can cause vomiting, yes. Adrenal, yes. CNS, yes. So what does not cause vomiting? And of course, GI also does. So where is the anatomy of this vomiting? Give a thought. Could it be infective hepatitis coming? Typical vomiting, nausea, and wait for jaundice.
Why no?
Infective cause is less likely because no fever and uh, even liver involvement is less likely because no jaundice or no otherwise not that sick. Well, as per history doesn't look that sick.
So why isn't it not acute hepatitis? Or why sir said why is the vomiting not due to liver involvement? So the progress doesn't tell you that it is due to liver involvement, right? So one, you said icterus should have come up, that icterus has not come up. and this is vomiting off and on over 2 weeks. So that is not the progress of a acute liver disease, right? Can it be simple acute gastroenteritis? So in acute gastroenteritis, how long does the child vomit?
2 to 3 days child should in hello in 2 to 3 days child should be recurring.
So this child has not recovered in 2 to 3 days. So what could be the reason?
When story starts with vomiting, it's obviously mostly GI. Rest all conditions which I talked about, vomiting is preceded by something else. An acute hepatitis, severe anorexia, nausea, vomiting, then comes hepat. So there is severe anorexia, sickness. If it's neurological, there is headache, irritability. If there is an adrenal, you will not know it, but it can go on for a long time. That's the only one that can go on for a long time. So this is not liver, CNS, etc. But vomitus does not contain bile. So it has to be prior to second part of duodenum. So largely stomach. So the anatomy is stomach, not esophagus, not duodenum. Okay, theoretically first part of duodenum, but that alone is not. Second is it's not progressive. It's not an obstruction like an annular pancreas or some pyloric stenosis. It worsens. Therefore, this is non-surgical stomach as an anatomy and persisting for 2 weeks. How do you put it? And some discomfort in abdomen, and therefore this is indigestion. Indigestion is a vague term. Okay. What do you mean by indigestion? Many mothers come and say, "Their digestion kharab ho gaya." That means vomiting, no? What is indigestion medically? Very common layman's term. Okay. What is indigestion? First tell us what is digestion. Then we will say what is indigestion. What is digestion? Difficult, no? Yeah. Sometimes when we learn a lot, we forget the basic. So that's the thing. What is digestion?
Breakdown of the food particles into absorbable substances that can be absorbed through the blood, the nutrients.
So for an absorption, you must have a digestion. And what is digestion? Turning into smaller molecules which can be absorbed. The larger molecules cannot be absorbed. And if larger molecule get absorbed in the intestine, it causes allergy. That's how animal protein going in, not digested enough, whole protein goes inside, it causes allergy. Okay, so digestion is that. And who does digestion? Stomach, pancreas, and a biliary system. But here, there is nothing like pancreas acute disease. Okay, it would have come up with acute pain, etc. Not mild, so it has to be a digestion coming out of stomach. Why should it happen so? Therefore, some digestive enzymes are not being produced well. So what's the cause? What's the cause? Why is the stomach not producing this? And thereafter diarrhea. Diarrhea is the result of maldigestion. When you don't digest food, it cannot be absorbed. So it has to be passed out as diarrhea. So this has been indigestion to my mind. But why is that so? So one common cause of indigestion at that age is a severe malnutrition. Okay. And therefore it has taken time. So we must ask further history to suggest malnutrition. What history would suggest malnutrition? Then we have diagnosed.
So dietary intake, this child is mainly breastfed and not having other dietary nutrients.
Would it be malabsorption with good appetite? You're right. Diet is poor. But malabsorption is a good diet, no? But that is malabsorption. We are talking about maldigestion. So you would have got that. Suppose mother said, nahi, acha khata hai. Then you have to ask for something more. What that is something more?
Consistency
Not
of the
gaining weight,
stool.
fine. Most of them don't weigh. You're right. Your answer are right. What else?
Of the stool. Stool.
Stools, how are they?
Most important is behavior. And what's the behavior of severe malnutrition? Rest is right. You're right. But it's,
Pathetic, irritable.
Apathetic, irritable.
so you would say if it's a calorie malnutrition, he is often hungry. He wants to take, but he vomits. Okay. If it's a protein malnutrition, then he's lethargic. He's not interested. So, in typically a malnutrition, which is PEM, you have largely a behavior disturbance, often calorie more than protein. Then you have a hungry child but cannot digest, vomits, gets sick, then appetite is low, so irritable. And if it's protein, little more than calorie deficit, more of drowsiness, again, loss of appetite. So loss of appetite, drowsiness, disinterest in playing. On the other hand, wanting to eat more, but still not taking it often, that is a calorie. So behavior change. Okay. He's not sick, but he's still chronically irritable, behaviorally not normal. Plus, what you said is right. Okay, weight, diet. So this looks like to me simply a malnutrition. Now you'll have to decide what it is. And therefore, how did we arrive at that? We said it's a stomach. That's how there is some problem of digestion. Therefore, gases must be there, often on some discomfort. That's what the mother says, abdominal pain. And then diarrhea, because when digestion doesn't occur, diarrhea is the result. And to me, looks like a chronic 2 weeks subacute. It's not an organic disease by itself, but it is probably a deficient enzymes, hormones, whatever. And I think that must be the cause.
I would like to point out two, 3 points here. I want to apologize because few points have been missed from the presentation. There was some technical issue. So before coming to Chayan Hospital, child has got his CBC done, which showed HB of 8.4 with hematocrit of 27.9, counts of 10.2 with platelet of. No, it's on my phone. Huh. With platelet count of 45,000. This CBC was done on 5th of April. Then we got another. They got another CBC repeated from outside only, which showed him hemoglobin of 8.8 with hematocrit of 31.8. Counts were 9.8 and platelet count was further still dropped to 34K. Then the patient was referred to sign for further management. Uh, On arrival, the child was febrile with pulse rate of 110 per minute, rhythmic, regular, normal volume equal on both sides, no radial or radiofemoral delay. Peripheral pulses were well felt, respiratory rate of 32 per minute, SpO2 of 9 to 98% on room air. BP was 100 by 60, which is 58th percentile for the child.
Wait. How do you have a rule of thumb of 50th centile of BP? Of course, you always look at the chart, but how do you have a rule of thumb of third centile or fifth centile? Because then you can go by rule of thumb and say, oh, this BP is too low.
Fifth centile is 70 plus age into 2.
So, what should be the fifth centile of this child?
The age of the child is almost 3 years, so 76.
So, 76 should be the fifth centile, below which you would be worried. Now, how do you get the 50th centile? 90 plus age into 2. So, it should be 96. What I'm trying to say is 100 by 60 for a 2-year-old strikes you as a little too much. And then 100 by 60 is also the figure which is universally used when you don't take the BP. So examiner will think that this is not taken BP. So at least cheat and say 98 by 58. Okay? That's the point.
Father was present, extremities were warm. Answer-wise, the weight of the child is 9.5 kgs, which is less than third standard deviation. Height of the child is 77 centimeter, which is also less than third standard deviation. MUSC is 13 centimeter, which is between -3 to -2 standard deviation. Head circumference is 45.9 centimeter, which is between -2 to -3 to -2. Weight by height is less than -3 standard deviation. Impression-wise, the child is severe acute malnutrition.
So when did this SMA start?
Sorry, sir.
When did the malnutrition start? Obviously 2 weeks ago, right?
Yeah, but at the first admission at one
No,
year.
no.
No.
Sir is asking from the indices. From these anthropometry, everyone guess and tell us. Guess means analyze and tell us. So first tell us what is this weight corresponding to what age?
It is below -3 stunting.
9.5 is the weight at what age? 50th centile at what age? 1 year. Birth weight was normal or we don't know? 2.8 kg. So 9.5 is 1 year. 77 centimeters is what age? Pediatrics में आके you have to be little more accurate. 77 at 1 year is tall. So 1 year, 2 months or whatever, right? So weight of around 1 year, height of around 1 year, 2 months, and chronological age of 2.5. Now answer sir's question. When did this start? And remember, I'm giving you a clue. It is not that at 1 year, 2 months, the height button was switched off and then no further height. This didn't happen or this doesn't happen. So now tell us when did it start? Less than 1 year. So that is for sure. Now be more accurate. When less than 1 year?
Will you be able to draw the graph of a height and weight of this child if we had the graph?
So maybe she is too junior, but they can maybe collectively do it. So less than 1 year, everyone has understood this, that height and weight cannot be just switched off at 1 year and 1 year, 2 months. So it started before that. Now try to go further and say when did it start?
At the time of weaning, complementary feeding was not
Okay.
properly established.
So why do you say that? Means there has to be a logic behind it.
The child is 2.5 years old and still breastfeeding. Prefers to have breast milk over and above other complementary foods. So
Okay. So suppose this child was nicely breastfed till 6 months of age. What would be the weight and height of this baby at 6 months? Guess.
Around 5.
But it was how much? 2.5?
5.6.
5.6 at 5 months. So 6 months, how much? 6.5 or so. Okay, 6.57, whatever. What about the height at 6 months?
666. At 6 months, 66. Maybe a little less, a little more, depending upon. Okay.
So what we are trying to tell you is, then this baby's feeding was improper, so the weight did not gain the way it should be, and there was very little weight gain. Then that problem continued. So then height also did not gain. So you have to see how the next 10 centimeters or so in height gained over the next 2 years. मतलब 6 to 12 में normally how much height do you gain? 6 months to 12 months? 10, 11 centimeters. Instead of that, this child has gained in 2 years. So roughly, if you go backward, you will decide that this must have started at about 6 months. First, weight started getting affected. Till 9 months, height was not affected. So till 9 months, height must have been 70. Then height started getting affected. So it has gained very slowly, and in this period, it has reached 77. Roughly, this is just a rough way.
Actually, this child should have been about 88, 89 at 2.5 years. So if he said 89, he's short by 12 centimeters. Okay. What does it tell us? That it must have happened very early that the child lost a fast growing period. Now, what is the fast growing period? The fastest is first 3 months, and the next 3 months is a little less than fastest. So it must have happened somewhere between 3 and 6 months. What does it mean? He was not exclusively breastfed for first 6 months. That is sure. He must have been breastfed for 3 months or even not that. So your diet expected with this parameter says he was never breastfed till 6 months. So right at 6 months he has started faulting. And thereafter the growth as such slows down. So the faulting was not visible to an extent, and therefore weight and height looks reasonably close. Weight for height is nearly normal, but it indicates that the problem started very early, and I would say by 3 months of age or even earlier. So then, of course, we know that it was a full term 2.5. So the reason is, why should it start at 3 months? Let's believe it started at 3 months. Do you think it's primary? Starting at 3 months, or we are missing some hidden illness causing malnutrition. Whatever happens early is primary. Okay. And on, can it be primary nutritional problem or secondary to a hidden cause? For example, the hidden cause could be a renal tubular disease, failing to thrive. It could be cystic fibrosis. Okay. And then we will just say nutritional rehabilitation will go wrong. So, who will comment whether it's a primary nutritional problem or secondary?
So secondary means what? Secondary to heart disease, secondary to kidney disease, secondary to any other GI disease. So what do you think, primary or secondary?
Primary cause nutritional, because child was normal till 3 months. Matlab, secondary cause would have started affecting him a little bit earlier.
Basically, what sir is trying to tell us is that primary, if you say, and if it starts in the phase when breastfeeding is the main source of nutrition, then be careful and re-examine carefully whether it's really breastfeeding failure. So breastfeeding failure, inadequacy, etc. is known, but you have to be very careful and not just loosely ascribe it to poor breastfeeding or wrong breastfeeding, right? That is the point sir is making. So whenever it happens in that period, think twice about an underlying illness.
We have been always told that breastfeeding children grow well, and exclusive breastfeeding children grow definitely well. But I recall maybe in early 70s when I went to Solapur I was taken to a rural area and shown exclusive breastfed babies 6 and 8 month old, severely malnourished. Why is that happening? No immune deficiency, no cystic fibrosis.
Exclusively breastfed, but not exclusively adequately breastfed. First 3 months, very good. And that is important. How was the child? खुश था पहले 2-3 महीना 2-3 घंटे से मांगता. Now first for 4-5 months or maybe after 6 months, he's asking for feeds very frequent. Gets up at night every 2 hours, wants to nurse, not very happy. Telling a well-fed child is a happy child and crying at certain intervals. This particular child is asking for food all the time. So 3 months okay, then coming down, and the weaning has not started at that. The mother may have realized that the breastfeeding is inadequate. They will understand, mothers are smart. But an effort to give an outside feed is rejected because of emotional attachment to the breast. So at that time, you really have to be very persistent. This is one crucial time where the doctor's counseling is very important because she's likely to देता है मैं देती हूँ लेता नहीं है, then I have to continue with breastfeeding. So you have to tell her some tricks or something wherein she should restrict breastfeeding and give semi-solids. Once the child starts getting weaning food or etc., once he gets habituated to that, then he starts taking. So that particular period has to be rather anticipated and told to the even a normal mother that after 6 months your milk is likely to fall short. So that the child should eat well at 1 year, we start at 6 months. Okay, so that he gets used to starting. So adequately and exclusively are two different words, and we need to do that diagnose from the history.
On head-to-toe examination, frontal bossing was present. Purpura were present on right ear and feet and forehead also. Rest of the head-to-toe examination was not significant. On systemic examination, per abdomen, soft liver was 1 centimeter, soft skin was not palpable. CNS-wise, the child was alright. RS-wise, air was bilateral equal, clear. And CVS-wise, S1, S2 heard there was no murmur.
So comment on this. First comment on frontal bossing and then purpura on right ear and feet.
Frontal bossing can be because of vitamin D3 deficiency.
Vitamin D deficiency. So we normally, what is the definition of rickets? Rickets is a disease of growing bones, and this is a malnourished child. So he's not growing well. Still you have got frontal bossing. So the first question is this nutritional rickets or is this renal rickets or some other complicated rickets? What do you think?
Most likely it's nutritional only because the child is nutritional, his diet history is poor, but I would like to investigate further to rule out all organic causes also.
Anyone else? So what happens to signs of rickets once they come up? Do they stay? Do they go away? What happens?
They go away after treatment, sir. Like if there is any bowing of limbs, it goes away, and widening of wrist also goes. And
So frontal bossing also goes away. So many times what will happen is you will see the signs of rickets which were acquired very early in infancy, because at that time this baby was not malnourished, was probably growing well, right? So those signs will persist. Okay. Now, sir's question is, what about the purpura? Why selectively in these two areas? What does it mean?
Why did you make a diagnosis of purpura?
Pateki, it was larger than Pateki and smaller than.
Did you
Yeah,
try to see whether it was blanching?
yeah, it was
How did you see that?
with a slight test.
Very
And
good. Was it palpable purpura or only?
Why do you have to use a slide? Why not your own finger to blanch? So now tell us, does this have any, so is this generalized petechiae or is it localized? Can it have some other reason? You said battered baby. So do you think this is battered baby? What does battered baby get? Purpura means petechiae or ecchymosis. So that's the difference. Okay, so not battered baby. Anything else? You already differentiated with mosquito bites.
I think let's call it a localized purpura. So it is not a systemic disease, whatever is the cause. Okay. And to that extent, yes, you said feet also, but this right ear is a very funny statement, right? So that means there is something like purpura ears. And what is that? Some bleeding occurring in the skin. Okay, that is all. So could a severe malnutrition cause that? Then we don't have to say ITP. Okay. And when I was trained, ITP was idiopathic thrombocytopenic purpura. Okay, not immune mediated. And we called many things idiopathic. And we said earlier that idiopathic is a idiot doctor and a pathetic patient. So we called many things idiopathic. Can malnutrition cause this? If so, then our diagnosis is made. Let that purpura be right ear or left ear, doesn't matter. What do you think? So is purpura thrombocytopenic or non-thrombocytopenic also?
purpura is mostly thrombocytopenic. It is a platelet disorder.
Yeah, but sir's question is, can sometimes purpura be without thrombocytopenia? Does such a thing exist? If yes, then we'll have to think whether this. So far, you have not seen the reports. Means you know previous reports. Wo jaane de. You are taking history, then you have found on examination history was of some prolonged GI disturbance. You expected a malnourished child. Now suddenly you are looking at petechial spots. So the question is this thrombocytopenia or no? Vitamin K deficiency will cause what? So clinically, ecchymosis, no, and then bleeding from wherever, not petechial spots. So which condition petechial spots are non-thrombocytopenic?
Vitamin C deficiency.
Vitamin C deficiency. Okay. Anything else? Non-thrombocytopenic purpura. Kare sir asked, is this palpable?
IgA vasculitis.
IgA vasculitis, the new name for henoch-Schönlein purpura. So that is non-thrombocytopenic, right?
So, in other words, this could be vascular purpura. Okay. And vascular purpura is a vasculitic disease. Vasculitic disease is acute, is sick. So this is not an acute and sick child. So the question is, are we really talking about purpura or even ecchymosis? And therefore, my first concern is this is unlikely to be a bone marrow disease. This is unlikely to be an immune-mediated thrombocytopenia. Okay. And therefore, is it a fragile blood vessels that is causing it? Though it should not cause purpura, but it should cause ecchymosis. So possibly that may be the cause. But if you are telling me it's thrombocytopenic purpura because your platelet count is low, I will not still buy that. I will tell you how to analyze low count, and this purpura is not due to that. Okay. So because you are saying that you put it ITP, okay. ITP is not a very localized thing. Okay. And ITP is an immune mediated disorder, more likely to be in healthy people, less likely malnourished child. So this is not an ITP. This is not a bone marrow disorder. So this must be vascular, but it's not vasculitic. So must be fragile blood vessels. And the reason why you may have a low platelet count is platelet count done on an automatic chamber is very, very difficult to decide. It's not reliable. Okay. And tell me why. Today, all laboratories have an automated counts. Okay.
How does a machine count platelets?
So machine can count RBC, WBC, platelet. How can machine know that? Artificial intelligent machine. Size, correct? So can something make a size small like a platelet, but it is RBC or WBC? So that does not happen. Platelet count may go up if it's a microcytic RBC, but the platelets can't come down because RBCs or WBCs are causing that. Therefore, there could be another cause of wrongly reported platelet count by the automation, and that is a small clot in your feeding tube. Now, how do you know it is not that? And therefore, every time you see a platelet count in an automated chamber, you must correlate it with a platelet count. And what is the correlation?
A peripheral smear should be done. I just got the report of the peripheral smear, which is showing platelet count of 24,000. For this,
Sir is asking how you correlate on the peripheral smear. Means what do you look for?
So what I want to say is that platelet count given by that automated machine is small, but really platelets are not small in number. The machine or the technician has had a fault. And how do you pick that up?
Clumps. So if you see platelet clumps, then large platelets tells you what?
immaturely, platelets are getting out of the bone marrow into the bloodstream.
Correct. So you are talking of two other things. So clumps tells you function is normal, large tells you young platelets are being released. What sir is asking is, if your platelet count is 50,000, can you look at the peripheral smear and say, this cannot be 50,000. This has to be 2 lakhs. Can you just look at the peripheral smear and say something like that? There's a thumb rule.
So in peripheral smear, if you look at the
High power
high
field.
power field, then the number of platelets seen in one high power field into 10,000 is the likely correct or around correct thrombocyte count. So if this child has got say 40,000, then you should see only 4 platelets in one high power field. But if you are seeing 10, then it is really 10,000. So that is the correlation. And I think platelet count is a very troublesome interpretive parameter. And a good laboratory must always give you the correlation and say that we have checked when it is abnormal. When it is normal, you need not check it. But here we did not expect the low count. And you have a low count. So instead of calling it as an ITP, okay, I would recheck on that. That's the way we go by, right?
So 3-year male child presented with symptoms of acute gastroenteritis since birth and developmental normal, which is probably a case of ITP according to me.
Even ahead of ITP, you should have said malnutrition for sure, no? So, with a poor dietetic history, case of malnutrition with maybe ITP, you could say, but malnutrition should precede that. Okay.
This is the CBC report of the child, which is showing platelet count. This is on arrival. HB of 9.2, hematocrit of 28.8, counts at 10 with platelet of 50. On PS, there is RBCs, hypo, micro, and anisocytosis was noted. PTINR of the child was 14.2 and INR was 1.18. RFT is 39.8 with electrolytes within the normal range. We did send a peripheral smear of the child to hemat lab today, so which is showing a platelet count of 24,000 on peripheral smear examination.
Okay, so now tell us, this thrombocytopenia is destructive or a production problem?
Destructive.
How do you know?
Because at the time of second admission of the child for dengue, the child was NS1 positive. Platelet count was normal at that time, and between that.
No, that is not the reason. No, this child can always develop a bone marrow aplasia after that dengue. No, so in this, we were just talking. No, which are the parameters which will tell you that this low platelet count is a production problem or a destruction problem? So immature platelet fraction is that number, but in a very crude way, we are looking for presence of immature platelets in peripheral smear. And you just said, how do they look? They are larger platelets. So even if you don't do the IPF test, if you just look at the CBC, you have something called mean platelet volume. So if you look at that and that is on the larger side, you have more immature platelets. So that is one. And presence of giant platelets, presence of clumps, etc., will tell you that the bone marrow is producing a lot and therefore it's a destruction problem, right? So that is the way to judge just now whether it's a production. What about the other series? So hemoglobin is also low. So we have bicytopenia. So could it be a bone marrow problem? No. So yes means look at the hemoglobin also carefully. Look at the indices and tell me whether it's a bone marrow problem.
So he is asking what are the indices in a bone marrow disease causing low platelets and low hemoglobin.
Come on, in a bone marrow problem, if the hemoglobin is 8 or 9, what would the indices be? Would it be microcytic, hypochromic? No, then what would it be? Normocytic. So here it is microcytic hypochromic. So that is your strong point, that this is not 8 or 9 because of bone marrow. So if hemoglobin is not low because of bone marrow, then platelet also is unlikely to be low because of bone marrow, right? That is one. Now if it is microcytic hypochromic, then it should be, what are the two commonest DDs? And deficiency and Thaltrate. Now which one is this? मेंजर इंडेक्स के पहले अभी आरडीडब्ल्यू दे रहा है मशीन, तो यूज करो ना. आरडीडब्ल्यू इज नॉर्मल, so this is Thaltrate, correct? Correct. So why are you shaking your head? You are right, this is not Thaltrate, but then explain. Why should it be a microcytic hypochromic? So what are the other things that you look at in Thaltrate? Now your Menzer index comes in.
RBC count and hemoglobin correspondence.
Yeah, so RBC count should be disproportionately high for the given hemoglobin. Is it so here? It's not. So that is why this is not Thaltrate. So then why still microcytic hypochromic? So you could have a dimorphic anemia and you could have a kind of a equalization of indices. This is a malnourished child, maybe B12 also. But I still can't explain why RDW is not high. That's a bit of a surprise, because in dimorphic also there will be a lot of variation in the sizes of the cells. So the distribution width should be higher. Okay.
In fact, typical B12 deficiency may have a pancytopenia, and therefore we are looking at low platelets, low hemoglobin, and therefore I think it's unlikely an ITP by and large. Okay, but because she has put up ITP, my question is, how would you rule out ITP in this child? Are you going to give steroids if it's an ITP? So you'll have to confirm ITP.
Usually clinical diagnosis, sir. Otherwise, bone marrow. We can bone marrow. If clinically strong diagnosis is there, need not do bone marrow. Or
My understanding is that in which malnutrition there could be such a picture, whether there is a chronic indolent infection. And I will rather search for infection, and I will repeat the count again, but not rush in to call it ITP. A chronic infection is often a bone marrow suppression, and this child is at risk of chronic infection. Okay, especially more so if you are given an antibiotic, which is not the best antibiotic. So it's a suppressed infection and is becoming a chronic infection. If that is so, bone marrow may be suppressed, and if the bone marrow is suppressed, this anemia is a combination of chronic infection plus the deficiency B12 and iron, and therefore we are getting all mixed up. To say LDW is normal, so where is the deficiency? At the same time, malnutrition, so must be a deficiency. So some parameters are counteracting each other, and that's why this is difficult to interpret. But clinically, this should not be TP. Clinically, it should not be a bone marrow aplasia, but clinically, we must search for a chronic indolent infection.
Which chronic infection? Tuberculosis?
Yes.
Commonest chronic infection.
So which chronic infection is likely to suppress bone marrow?
Chronic malaria. Okay. Come on. Huh? Parvovirus is selective to the hematopoietic system kind of HIV. Okay. So many times what looks like ITP has been occasionally picked up as HIV, as a first episode of SLE. So these are the other things which masquerade as ITP, right?
Explain malnutrition and failure to
Yeah.
try.
So further, anything has been done?
Child got admitted just yesterday, so I'll also send
Okay.
HIV
And
sample.
but have you started treating with steroids?
No, not yet.
Why? Why have you not started? We are asking. You're right, but we want to know why.
Yeah, because the clinical picture was not fitting. There were not many, matlab, other ITP children we have seen which have got purpura on whole of all body parts and all. But this child is not showing so many manifestations of ITP. That's why.
Also, all ITPs don't need steroids, no? So unless the bleeding manifestations are so bad, you don't have to necessarily start steroids, right?
We have sent the infectious workup also, which will come by tomorrow.
Okay.
And the primary problem of presentation of abdominal pain, vomiting, and loose motion still remains.
That might, sir, you are right actually about that. That might point to a chronic illness like HIV. Though if the child is not recovering from illness, so maybe it's a bigger problem we are looking at.
Okay.
Thank
Any questions? I will stop here. Any questions from the online audience? Any comments?
I wanted to thank Dr. Amdekar for summarizing the first case so beautifully. And can we get a follow up of
Any
the
comments or any questions from the online audience?
No, sir.
Okay. We'll stop here. Thank you. We'll meet next Thursday again. Thank you.